I can still remember the moment that the ambulance arrived at the house to take me away, and it felt like that. The condition caused me a lot of pain and certainly almost total immobility for a few years. I was hospitalised for several months on end, in and out, in and out. It pays back, this stuff pays back. It's a health system continuing to choose to organise itself in a way that makes it more costly than it needs to be. My jaw was literally on the floor. I've fallen in love with you twice.
Hello, this is Michael George of Sages Healthcare Consulting, and this is the Pioneering Patient Podcast. This episode is brought to you with the support of the Global Remission Coalition. Now, recently I met the renowned patient advocate Neil Betteridge when he was in Geneva. We had a fascinating discussion about the value of the remission of rheumatic conditions. And this is what he had to say. Neil Betteridge, welcome to the podcast.
Pleasure to be here, Michael.
Thank you. Neil, tell me about what you do at the moment. What's your current role?
Right, well, I'm the Senior Director for the Global Alliance for Patient Access, GAFPA, which is an independent, not-for-profit organisation which seeks to support those engaged in policy advocacy to raise their voice and get their messages over to the general public, to policymakers in particular. So it's all about pursuing the best possible care for patients across a whole range of diseases. And of course, today we're looking at one example of that, which is rheumatic diseases.
Rheumatic diseases. And we're looking at the value of pursuing remission in those rheumatic diseases. So explain to me, what is remission and what are some of those rheumatic conditions?
Yeah, well, I guess remission is often associated in people's minds sort of most immediately or instinctively with cancer. And of course, if you have a loved one, a friend, a family member who may have had cancer and then achieves remission, that's a fantastic thing, isn't it? It's the best news you can hope to hear. But remission actually is an equally applicable term in a range of other inflammatory conditions, such as rheumatic conditions. And it's really about trying to get to that point where, to sort of coin the definition we are using at the moment at GAFPA, you have the absence or the disappearance of signs and symptoms. Now, it gets a bit more complicated than that when you look at, what does the X-ray tell you versus what the patient says and all of that. But really, we want each patient to have remission as the goal if they have an inflammatory condition. Not every patient will be able to achieve it, but it should be the goal for all.
And what is the value? We talk about the value of pursuing remission. What is the value of having that remission for patients and for society as a whole?
Well, that's right. I think that's a good distinction, Michael, because the most important, from our perspective, my perspective as someone who's been there, is that the primary value is that the patient is doing better. They have less pain, more mobility, less fatigue. They can get on with the life they want to lead. So that is far and away the primary benefit. However, very importantly, alongside that, we see benefits accruing more widely to healthcare systems. And suboptimal care is always wasteful. So really, by the value of pursuing remission is we're pursuing care that is optimal and less wasteful. And that makes a contribution to the sustainability of healthcare systems if patients are having to go to see their clinician, their rheumatologist or their neurologist or whatever less often. If they don't have, like I did, stay in hospital for long periods, which is also expensive. And of course, if they can go back to work or get a job or go to school, go to university, all of that in the end is making a net contribution to society. It's cost savings to society, really. So there's absolutely no reason why we shouldn't all be together in this fight to pursue remission. The value is palpable.
Yeah, exactly. So we want to go on that journey, but we'll talk later on about how well we're doing on that journey. But let's go back to your journey, your story. Sure. The age of 4 when you were first diagnosed. It must be pretty traumatic for you and especially for your parents, because at 4 you probably don't totally remember it. Tell me more about what happened.
It's a long time ago now. So it was pretty traumatic, yeah. I think it's fair to say that most kids are pretty resilient, and I think I was just a normal kid in that regard. It had something abnormal happen. But like a lot of kids, you just get on and do. You make the best of it, and you find the good things. You can still play, you can still talk to people, you know, you've still got a lot ahead of you. But of course, it wasn't a bed of roses. And as you say, especially I think for the families, because as you get older, you learn how to worry more, don't you? So I can still remember the moment that the ambulance arrived at the house to take me away, and it felt like that. But you know, I learned to read by then and I was falling behind with my comics. So I thought, great, I can catch up with all my comics now. So yeah, I think looking back on it, seeing the looks on my parents' faces, not only that day, but throughout that whole period, for those several years where I was disabled by this, probably caused me more anxiety than the condition did. The condition caused me a lot of pain and certainly almost total immobility for a few years. But I think the anxiety came from seeing the effect on my family.
So tell me more about that period. You spent a long period in the hospital, you weren't able to go to school. How was it impacting your life at that stage?
Yeah, it was. I was all set to start school and then couldn't. And it was almost a year later when I could, you know, in a wheelchair by that point. It was a shock, but at the same time, you sort of learn coping strategies without knowing the language around some of that. I was hospitalised for several months on end. Looked like there were signs of improvement. Came home, improvement didn't follow through. Back into hospital, in and out, in and out. I was in the English Midlands. The only specialist centre for juvenile arthritis was just north of London. And at that age, 4, 5, 6 years old, that's a huge trip. Well, it was for me anyway. I'd never been out of my hometown. And also the anxiety of what news are you going to hear when you get there, which every patient has when they go to see their doctor. You know, you're dreading bad news. And I think possibly one of the most shocking things, and hopefully and thankfully, parents of kids with rheumatic diseases these days won't be experiencing this, and I'll explain why shortly, was actually seeing a lot of the other children that were so much even worse affected than I was. Mostly for me, it was my knees and ankles, and it was starting to spread to other parts of my body like fingers. But some of the other children you would see on a visit to the specialist were so severely disabled, they clearly had no chance of getting their mobility back throughout their entire life. That was very visible, and it was quite shocking. So of course, my parents are thinking, is my child going to end up like that? Yeah. I remember my mother coming home one day in tears, and I made her tell me why, and she said she'd just heard that X number of children with juvenile arthritis go blind, because it can. It affected my vision. I've never been able to drive a car because of my condition, but I can see well enough to get around. But it's these fears that just mount. Uncertainty is always the worst thing, isn't it? If you know what you're dealing with, it's easier to just get on. But I think it casts so many shadows of doubt on families when a condition like this comes along. And the best thing you can do really if you're in that situation is go and get help, talk to other people who may have been in that situation and work out what you're probably dealing with.
Yeah, and it's difficult to put in words, but before I had arthritis, a small form of arthritis, I thought it was just a bit discomfort and difficulty to move your fingers. And then when I had arthritis, I realised it was nothing like that at all. So tell me more, try and explain in words how painful, what discomfort is like, inability to sleep. Tell me more about that, what you went through.
Yeah, I think what we have to do here, Michael, is flag the fact that the word arthritis is a bit of a catch-all. Yeah. Because if you look at all of the rheumatic, and to use the technical language, musculoskeletal conditions that comprise the family of arthritis, you've got a huge variety there. Everything from back pain, neck pain, gout, osteoarthritis, which is the form that a lot of people get as they get a bit older or after trauma. Those things are mostly your bones and joints not working well because you've had an accident or because of older age, wear and tear, etc. There is a family of that, a subset of that family, which is around inflammatory conditions. That was my personal experience. That's the set of conditions that GAFPA is working on, chronic inflammatory conditions, one example of which is rheumatic conditions. So You can have fairly mild aches and pains from, for example, osteoarthritis, because your fingers start to wear out a little bit. Rheumatoid arthritis can affect, and usually does affect, your whole system. It can affect the heart, the lungs, the tissues. It's systemic. It isn't just usually localized to one or two parts of the body. It's very, very combative.
Yeah. But for rheumatoid arthritis, the pain, what was that like?
Yeah, tough to deal with. Yeah, tough to deal with. And very difficult to describe. As I think people living with chronic pain often say, you know, there is no scale to convey it. And, you know, as human beings, when you're not in pain, toothache is awful, right? But when you haven't got it, it's like a distant memory. It's only toothache. But when you got it, it can debilitate you, right? Well, believe me, rheumatoid arthritis, juvenile arthritis pain goes way beyond that. You might learn to live with the constant pain that comes from the swelling, but the slightest touch on a swollen or tender joint can be absolutely agony. And of course, people then, and people's responses to this is probably as disabling as the condition. My wife had severe rheumatoid arthritis. It's well controlled, but she's had a lot of damage, so her pain and tenderness and soreness is off the scale, really. But she's tenacious, wants to get out and about. But if somebody in a crowd or on a bus or something knocks her knee, it can be agony, and I can see her, almost in tears, trying not to respond. And of course, the response from other people tends to be, "What are you talking about? He just touched you a little bit. What's going on?" And that's the sort of thing when we talk about stigma in inflammatory conditions like rheumatoid. This is sometimes what we're talking about. The pain is severe. You can learn to live with it. Then you get these flashpoints. But on top of all that, you've got people's attitudes. I don't know how many times I heard the phrase, "But it can't be arthritis because only old people get arthritis. You're 5 years old, So you not only have to deal with everything from the condition, you have to deal with being assumed to be a liar. You have to deal with disbelief. That is disabling as well.
And I think you talk about the fact that to dull the pain, you had to take aspirin, but there's only so much you could take.
Well, back in the Paleolithic age, or whenever it was I was first diagnosed many years ago, yes, only aspirin really was available. Some patients, cortisone, but that's a tricky one and not something you can rely on or do all the time, I think. It has its role, but, it's not the answer. So I was just taking aspirin constantly, obviously not exceeding the recommended dose, of course, but nevertheless at the maximum dose. I was, it was even before soluble aspirin, So guess what? If you know what aspirin does to you over a prolonged period, it makes the stomach bleed. And in the end, the stomach bleeds were as bad as the joint pain, and I had to come off aspirin. So then I'd got nothing except the pain. So now I can't take, ibuprofen or something like this, non-steroidal anti-inflammatories, because guess what? My stomach bleeds right away 50 odd years later,
So. So tell me about some of the treatments you had, because it sounds a bit harrowing. You even had to have your teeth removed.
This is a weird one, right? And before we go into it, don't try this at home.
No.
I have no idea whether this helped. I kind of woke up one day when I was in hospital, and I'd been taken down to the anaesthetic, to the surgical ward, I suppose, and woke up with none of my milk teeth, so no teeth, basically. My parents, rightly or wrongly, didn't want to stress me in advance, so didn't warn me. Forgiveness is all around, that's fine. And it was explained to me that there was a theory that there are so many nerve endings in teeth and gums that actually, if you deal with that, you can give your system almost a fresh start. Now, I believe I was way too young to understand this, and it was just a theory. A couple of years later, I started to improve and went on to achieve remission. Now, I have no evidence that there's a cause and effect there. Maybe there was. I don't know. It was a theory that was around for a while. I've spoken to rheumatologists about it since. They seem to remember that, yes, back in the day that was considered. It's not something that goes on now, I think. It's just one of those weird things. But I think what it illustrates is still the mystery that surrounds a lot of these inflammatory conditions. The mystery as to why. Why does it start? Nobody really knows. Often a combination of genetic components that may be dormant, may be triggered by trauma. I remember falling off my little tricycle when I was 4, and maybe that triggered something, but again, who knows? And then the mystery sometimes of why remission can occur for some people. That's also not fully understood. What we do know is that younger people have a better chance of achieving remission, especially drug-free remission, because these sorts of conditions, it's where the body attacks itself, the immune system. We learned a lot about this through COVID, didn't we?
Yes, yeah.
So I think people have a broader understanding now than they did back in the day of my day. But if you can find a way of preventing the body attacking itself, then that's when you can get into remission. That's what the newer therapies do, to put it, very top line. Babies and very young children have the strongest immune system, as we saw through COVID. Mm-hmm. And as you get older, your immune system tends to weaken. Yeah. So I'm pretty confident that I achieved remission partly because I was so young, but partly because I was doing some of the right things when I was encouraged to start moving, which I think helps. But none of this is easily definable.
Yeah. So you talk about when you were encouraged to start moving. This is when you came across Barbara Ansell, who's a renowned paediatric rheumatologist who turned your life around. Tell me about what she was doing, how she helped children.
The very wonderful and very terrifying Dr. Barbara Ansell. Yes, she was I think she was maybe the only paediatric rheumatologist in the country at the time, very pioneering in her approach, terrified the parents, probably the nurses as well, I think. Kids loved her, and they could feel the love, I think, the tough love. But it was very much, I don't know what they're doing to you in that hospital in the Midlands, lying in bed all day, get out, get moving, walk, you get some pain. When it gets unbearable, stop. And of course, that is exactly the approach now that modern day treatment of all types of musculoskeletal problems have. You must keep moving, right? Stay still, and it's only going to get worse. So she gave me lots of motivation to get out and do what I could. And also, and I'm sure any parents of children with whatever sort of chronic condition might recognise this, there's that tension on the parent side of, do I sort of protect the child? Because going through enough already, and if they start playing sports, they're just going to get knocked, and that's going to make them worse, and better they don't. Or do you say, get on there and take your risk? The net benefit will be greater, so get out and do stuff. And I think, in a way, Barbara Ansell and people like her give parents permission to take the cotton wool away and let the kids get on and take their risks.
So the cotton wool was taken away, you started moving, you got to remission, gradually over a period of time, and you were able to reinvent yourself from this child who was having to use a wheelchair, couldn't go to school. And what happened next?
Yeah, and you mentioned obese in your introduction.
Yes.
I mean, of course, if you can't move, you can't exercise, you put on weight, don't you? And in a broader sense, the connection between arthritis and obesity is often overlooked. Yes. Because if your joints don't let you move, how are you ever going to lose weight, right? So I did kind of reinvent myself, I suppose. It didn't feel like that at the time, but looking back on it, so I suppose Betteridge 2.0 was able to move around. Suddenly, not suddenly, gradually I could walk, then I could run, and then I could kick a ball. Then I found I was quite good at it. So at 5 long-term hospitals, 7 in a wheelchair, 9 being able to walk, being made captain of the school football team was a small thing and a massive thing for me, and also sort of symbolic in a sense. So I literally and metaphorically got back on my feet. And since then, I suppose, without this wanting to sound lofty, it's been about, for me in my life, it's been about trying to sort of give back a little bit, but not in any sort of lofty way, I hope. It's more anger, I think, to a certain extent, the anger that came from the experience. I do advocacy, right? This is what I do with GAFPA. That's what we do at GAFPA. We support advocacy. my favourite definition of what advocacy is it's the pursuit of change in support of a cause. I think that kind of nails it. But my personal favourite definition is that it's channeled anger.
Yeah, yeah.
You know, you don't want other people to go what you've had to go through if it can be possibly avoided. And I felt angry that it happened to me because there was lots of things I couldn't do. With lots of benefits from it. It made me, I think, a more reflected, considered person. But nevertheless, it was horrible.
Yeah.
Let's do something about that.
Yeah. If it's channeled anger, it's clearly channeled anger because you don't come across as angry, Neil. So let's just say that.
That's the channeling.
So, yeah, exactly. We'll come back to his adult life in a minute, but we're able to bring you these great patient stories because you watch, and also it helps if you subscribe. So please hit the subscribe button so we can continue to bring patients like Neil. So Neil, let's go back to your adult life. You talked about giving back. Your childhood experiences motivated you to move into advocacy. Telling me how you got into that field.
Yeah, well, I went to university. I went to Liverpool. I wanted to study English. They had a great English department, but they had a great football team as well, the red version. And so I moved there and immediately got involved with the Community Action Scheme, which is a scheme set up to help students do community-based projects, volunteering alongside their studies. And I became the president of that. And I wanted to work in disability, you know, especially with kids for obvious reasons. And at that time, I still didn't know that there were organisations like the one I went on to work at, like Arthritis Care. I didn't know there were patient groups. It just was unknown to me. So I went through university, I did a second degree, carried on doing the voluntary work, wanted to work in the voluntary sector, you know, the part of that community thing where disability services are often based. And lo and behold, found out that there were organisations dedicated to arthritis. So, wow, hallelujah, you know. And in fact, there was one particular moment, I've been very lucky in my life. After an unlucky start, you could say, I've been so lucky, Michael, with opportunities later. And one such was when I started looking for work. I'd had a belated gap year in Italy, teaching, putting off getting a proper career for as long as possible, I think. And but eventually reality kicks in and you have to sort of, you know, pay the bills. And I started looking for jobs in those days, you know, newspapers. And literally one of the first vacancies I saw was this organisation called Arthritis Care, looking for a young person, and I still was then, somebody under 30, to organise self-help networks of other younger adults with arthritis. And I couldn't have, you know, I thought I was dreaming, didn't know jobs like this existed. And I was lucky enough to get that job, part-time, junior, and then built up from there into other more sort of senior positions. That was my first step on the ladder, so to speak.
Yeah, and fate and luck seems to be playing a role because you went to work for another organisation for a while, and then you were called back to Arthritis Care.
Yeah.
You became, I think, Director of Public Affairs, and also a momentous moment in its 60th anniversary when you played an important role in that, didn't you?
There are a few benchmarks that the organisation was able to, I think, rightly sort of say, yeah, we did something there. I think you're referring possibly to the launch of the government's new healthcare reforms, and whatever we think about the UK government's plans back in those days, what was important, I think, was that arthritis was finally recognised as a major condition, because to launch the reforms, the Prime Minister and the Secretary of State for Health, and in fact the whole Cabinet, were gathered in Number 10 Downing Street, Prime Minister's residence, and invited half a dozen, 6 or 7 chief executives from health organisations, and Arthritis Care was one of them. So from where we'd started a few years earlier, when the government seemed to only want to talk about the recognised priorities like cancer and diabetes, which should be priorities, but arthritis should be too. It was a major step forward. So we felt there was some recognition there. And actually since then in the UK, arthritis musculoskeletal has gone on to be recognised as literally a major condition. So you can see progress was made, yeah.
The other progress was, I think, you were the first patient chief executive of Arthritis Care.
Yeah, my mantra in various settings I've worked in has been, and this is a kind of shameless borrowing of a previous civil rights slogan, but I make no apologies for that. Nothing about us without us.
Yeah.
You know, patients have a right to be involved in all discussions that affect their lives, their services. And so I kind of made that my mantra at Arthritis Care. And in that period, the organisation had been around since 1947. And in 2005, I think it was, I was appointed chief executive, and I was the first person to have been appointed to that role who has experience of the condition. And a year later, we had our first chair, someone with personal experience. So this term user-led organisations, where the people who, the experts through experience are actually shaping what the organisation does, you could see that becoming a reality there. And I think across the health community, we've seen that progressive thinking kick on. I'd like to think we were fairly pioneering in that regard.
And you also play an important role in EULAR, which is the European Association for Rheumatic Organisations, I think. So tell me about the role you played there. Yeah,
I was Director of Public Affairs at the time, Arthritis Care, and I'm very collaborative, and I think this is something that across different diseases and so on is really important. To find the Venn diagram with a nice overlap of interest. The technical jargon in policy terms would be strategic alliances, but at a more sort of heartfelt level, I just felt, well, there's organisations here who are doing things which actually, if we connected with, would bring benefit to the people I'm here to represent and serve, you know. So I could see that EULAR was one. It had resources because this was early 21st century, new therapies were coming through. I remember a rheumatologist back in the day, in the 90s probably, saying, arthritis and rheumatoid in particular will never become a priority until it's expensive. And a lot of people went, because that seems so counterintuitive. But it's absolutely right. As soon as the new therapies, which were expensive but very effective, we're talking about the biologic therapies, came through, attention had to be paid, right? Because they were fantastic, efficacious, good safety profile, but a big cost tag as well. What do we do here? So suddenly conversations, were being had. And EULAR, as a major medical society, was doing a lot of good things, education and so on, but actually didn't seem to me to have the patient voice anywhere in it particularly. Yeah. So I was lucky enough to become elected in 2001 as the vice president, representing the patient groups from across Europe, groups like Arthritis Care, but from all of Europe. And I made it my mission to try and mobilise that network and get more of a seat at the table, a voice that really was heard. And we made good progress. We changed the name, used to get private funding for its work, but EULAR reached a point where it said, no, hang on a minute, you need to be part of the family. Yeah. So we will resource this now, as long as you don't take any further commercial funding. Yeah. And that was the deal, and that was over 20 years ago. And EULAR stuck to its word, hats off. And the patient movement has stepped up, bigger hats off.
Yes, exactly. And you talk about the biologics, and you were in it at the start as part of Arthritis Care, advising or giving your input to NICE on the use of the biologics.
Again, a new entity. It formed in 1999. It was just at the turn of the century the biologics came through, and everyone was, in our world, was going, wow, the potential here. But how does this sit with NICE? Is NICE going to just be looking at cost? Because these things are expensive, relatively expensive, but they're effective for so many people. So I felt it was really important to try and get a voice into that. And, across other countries, health technology assessment boards like NICE, this is an ongoing debate. How do patients get their voice raised when therapies are being assessed? So in those days, as it happens, one of the first major appraisals NICE ran was on a biologic, particularly for use in rheumatic conditions. And fair play, NICE shared the scope of their appraisal with me, with the organisation, before it was confirmed. And I suppose one of the things I'm proudest of, but it's a very personal bias because of my childhood experience, is that when I was reading it, I noticed that children were not included. Yeah. There was no mention of juvenile arthritis. In fact, it specifically referred to adults. So I picked up the telephone and tried to get through to the chief executive of NICE. He'd sent me this to look at after all. And fair play, got put through and spoke to him and pointed this out. And he said, Yes, let me look into that. An hour later, phone call back, you're right, we missed it, children are in.
Wow.
So if that had never happened, I don't know how long it might have taken before children could, qualify for access to therapies that can be, life-changing.
Yeah, so hats off to you for
well,
that.
Team effort, all this stuff is.
Exactly. So tell me about the benefits that biologics are bringing and were bringing at that time.
Yes, first there was one and then another, and suddenly you could start talking for the first time about patient choice in terms of therapies for rheumatic conditions, including juvenile arthritis. So really, it kind of felt like this could be, should be a golden age, really. Aspirin back in the day, just aspirin, right? So now we're talking about complex things which, for a lot of people, work. And thankfully, as further alternatives came through, if one didn't work or stopped working for you, there was somewhere else you could go. So, of course, access to any therapy, including ones which are relatively costly, is always a big conversation. But, NICE and health boards across Europe and the world recognised the effectiveness, the efficacy. It's always balancing the cost and the effectiveness and the efficacy and the safety, isn't it, quite rightly? In actual fact, I've been nice to NICE just now, but I'm going to be not so nice to them now, because for a long period, patients in the UK faced restrictions that you wouldn't find in the rest of certainly Europe. So, for example, you had to fail on the cheaper alternatives first. Whereas what we know is these therapies, the biologics, work better if the patient is treated early with them. So that became the next fight, to try and get those restrictions lifted. So anyway, that's a long story, but they've gone on to have a good efficacy and safety record, which is the biologics as a whole, as a class, which is great. And of course, now we've got even further new alternatives as well. So it should be a golden age, but it isn't. And that's why GAFPA is launching and pursuing the value of remission as a concept and as a movement and as a campaign. And I can give you my view as to why I think this is so timely and important, with all the bias, given the fact I'm involved in the work itself.
Please give me your opinion.
Well, yeah, my view, and I relate to this personally, especially with my wife who's got RA and is still disabled through that and other factors, is that the advent of the biologics meant people suddenly felt, oh, we've got something that works, And it's right to be appreciative of that, because for goodness sake, the alternative before that was pretty dire. And I think possibly over the years, over the decades now, people have felt a certain sense of comfort, maybe complacency, and people here I'm talking about healthcare professionals, healthcare systems, maybe in the patient community even. I don't want to upset my friends and colleagues who I love dearly, and I include myself in, but perhaps we all got a bit too blasé that there was stuff out there that was working pretty well. We should be fighting for the best possible care, the best possible outcomes for every single individual person living with an inflammatory condition like rheumatoid arthritis. Why aren't we? So GAFPA having introduced this topic to the rheumatic disease community across the world, we've had meetings in Mexico and Colombia and Singapore, as well as Europe and so on. It's 5 continents are involved in this movement. And we're only just getting going. It will expand. There's a universal sense that this is right. We've perhaps taken our foot off the gas a little bit, and the shortfall between decent care, where your disease is reasonably well controlled, versus remission, or at least the best possible disease control, is really significant. It isn't just a little bit of difference. It can be the difference between being able to work or not, or being able to work full-time or not, or between living with daily pain and not having daily pain. So, decent care, we should be grateful that this has happened and thank our lucky stars, but we should also feel entitled that better is possible. And if people aren't getting the best, we should be angry about it.
And one of the reasons we're angry, there's an economic, isn't the immediate response is, as you said, it's expensive, but the economic arguments also in favour. What's your response to that?
Well, we talked briefly, didn't we, about the value and the value accrues to the patient in terms of quality of life, the most important thing, for sure. But yes, if it pays back, this stuff pays back. And especially knowing that this treatment early on in the patient journey can make so much difference and so greatly swing the likelihood of achieving remission. So all of these systemic barriers like delays to diagnosis and delays to getting to see a rheumatologist or whatever the, neurologist, whatever the disease is, it's ridiculous because it's a health system continuing to choose to organise itself in a way that makes it more costly than it needs to be. That is why we're talking about the value. We're pursuing remission not only for patients' sake, we're pursuing remission for the sake of sustainable healthcare systems. And you'd have to be pretty stupid not to recognise that it's something worth considering.
It's when people say the health service becomes a sick service because it's actually just managing sickness. And one of the things is 12 weeks is the time from diagnosis to remission. That's what you're looking at. Tell me more about how that's important, how you can get there, the role patients can play, the role GPs can play, the role the secondary service can play as well.
Well, there's a lot of big questions.
Yes.
But they're good ones. They're very valid ones. Yeah, absolutely. So there's good evidence to show that if you have a chronic inflammatory condition, like in this case rheumatoid, that if you are diagnosed and treatment starts within that first 12 weeks, your chances of excellent outcomes and remission are way more likely than if you're treated later. But people listening to this shouldn't despair if they are on a longer journey. It's not like a cliff edge and you fall off. It's just better. Earlier is better. Earliest is bestest, right? And that's how we should be thinking about it. But the reasons why that isn't happening more often, so that we get more payback financially and quality of life, is manifold, because we use this journey. I know it gets a bit overused, the patient journey, but it starts with the person thinking, I've got aches and pains that have come on really quite suddenly. Oh, it's probably just a bit of osteoarthritis. I won't trouble my doctor with it. If it's causing you pain and if it's come on quite quickly, it might be something a bit more than the advent of osteoarthritis. It probably is, because osteo tends not to come on quickly or suddenly, right? And that's a serious condition in its own right. Anyway, but that's another story. Go and see the doctor as soon as possible. What have you got to lose? If you get reassurance, it's nothing to worry about, you're fine, you can, no anxiety. If there is something to look at and maybe treat, you're off to a flying start. So don't delay. GPs sometimes are part of the delay, and it's not a criticism of them as individual practitioners. A lot of this is how the system works. They are gatekeepers, and they have disincentives around referring, because the referrals are expensive. They need to feel confident that when they make a referral to a specialist like a rheumatologist, that they're getting it right. So rather than kind of beat them up over that, why don't we help them? If we're looking at examples of good practice, I mean, I'm from the UK, I know the UK well, but it is actually a good exemplar, I think, here. You're seeing community-based triage services now, where if there's a suspicion that someone might have something more than localised aches and pains, they're seen pretty quickly by a multidisciplinary team, could involve a podiatrist or a back pain specialist, physiotherapist. And so you get a bit of triage going on. And if those people need access to local musculoskeletal services like physio, great, they get that pretty quickly. And if not, they get to see the specialist more quickly than they would have done. So that's the kind of way we can support GPs to make earlier and more confident referrals. And that speeds up the journey from the patient getting symptoms through the GP into the hospital, and then you're still probably within the 12-week window where you can make a massive difference. Those are some of the solutions that exist, and there's good evidence to show that these practices work.
And I'm going to come back to it, but I want to go back in your life, talk about how fate has impacted you. When you first joined Arthritis Care, you read a newspaper article. When you came back to Arthritis Care, something happened. Tell me more about that fate and the romantic side.
You're a naughty boy, Michael, asking me. Okay, I'll share this little personal story then. Yes, why not? It was actually when I was in the junior job at Arthritis Care, my first time. I was reading the Charities magazine and found this inspiring story featuring a young woman who explained juvenile arthritis as a teenager. Had it far worse even than I did, but here she was, and she'd come through that. She was back on her feet and she was working at the charity. And also the photograph of her made me think, she looks very, very nice, very powerful person, but really quite inspiring on all sorts of levels, shall we say. So anyway, fast forward 7 years, I go back to work at Arthritis Care. I think I kept the magazine back, and it was mainly for to read the inspiring story, I have to say. And I meet the staff, and that's all good. And one of the staff there eventually, over time, became my partner, my life partner, Kate. And the inevitable trip to meet the parents in Wales. I met Kate's mum. Her father had sadly already died. And it was lovely. The mother was just as nice as Kate, lovely. Yeah. So I thought, this is good. And I just started to walk around the family home for the first time, looking at the bookshelf. And on the bookshelf was a photograph in a frame, the same photograph that had played its part along with the story in inspiring me all those years earlier. And I think my jaw was literally on the floor at this point. And I turned around and, let's be cheesy about it, and said, I've fallen in love with you twice. So yeah, a nice moment. And so connected with all of the issues we're talking about in terms of experiencing arthritis early on and resilience and giving back, etc.
And I suppose in a way, if you never had juvenile arthritis, you'd probably never have met Kate.
Exactly.
So fate has its role to play. And talking about patients, how important is patient choice for rheumatic conditions and the patients?
It's hugely important, and of course you can't choose something that you don't know exists. So this immediately brings into the conversation, how do we ensure that patients are genuinely empowered? And empowerment is another of those words. It's a really, really important concept, but we have to use the word precisely, I think, and explain what we mean by it. It can mean different things, but we need to be precise. And for me, information is power. I mean, again, cliche but true. And so in the context of a patient talking to a clinician about what's going on in my condition, what's feasible, what can I expect, what are my treatment choices, you want that to be the best possible conversation you can have, because this is about the value of pursuing the best you can be, which could be remission. So there's a reliance there on the clinician to help the patient understand their treatment options. But to save time, if the patient can go into that conversation knowing a little bit at least about that, that's good. Because, doctors are strapped for time and restricted in that regard. It's hugely important, though, to invest a little bit of time at the beginning for the relational side of that conversation so that trust can grow up. Sometimes the specialist nurse can play a big part here if they have one. This is, again, part of the solution. In some countries, in some settings, some places don't have them, but where you do have specialist nurses, often they have a little bit more time. They're still really busy, but can maybe talk in more or less the same language as the patient sometimes, a little bit more, and that they don't have this sort of slightly imposing white coat thing. Yeah. So the patient's more relaxed, maybe takes more information in. So you can't, again, it's a bit like the GPs. We're not blaming individual doctors for this, but sometimes patients have conversations about their treatment choices without the full information as to what could be available for them. And you can't ask for something you don't know exists. So patient groups and campaigns, advocacy issues like GAFPA's Pursuing Remission have a huge role to play here in raising awareness. Yeah. And getting people to know that not only are they entitled to the best available, they need to know what is available, because you can't have one without the other.
And you raised the role of patient groups and patient advocates, and that's very important. You spoke earlier about there should be a golden era, but it isn't. So as a patient advocate, if you were invited in to see the Minister of Health in the UK or the head of the WHO, what calls to action would you have? What would you be saying needs to be done so you can achieve that golden era?
I mean, at the global level, and I'm, work for the Global Alliance for Patient Access and also volunteer with the Global Alliance for Musculoskeletal Health, and we do talk to WHO. So this is really important because we want top-down as well as bottom-up pressure to prioritise these conditions. I would say, well, take a look at the website of the Global Alliance for Musculoskeletal Health. There's a global framework describing a strategic approach to making rheumatic diseases and other MSK conditions a priority. This is kind of how you approach it. At the national level, and this is where most decisions get made, right, closer to home, we have examples of good practice. So my message to the minister, the health minister, or anybody who is in a position to do something about this, I would say, stop looking a gift horse in the mouth. Get on it and ride the damn thing, because we know what works. We have the solutions. We have evidence-based policy solutions. We have good practice underpinned by evidence that brings these benefits, that get patients seen earlier, that increase their likelihood of achieving remission. And in all of that, patient organisations and the network at GAFPA that we're supporting, we can play a positive and constructive part in that. We want to be partners in that. Nothing about us without us isn't just a rallying cry, it's a piece of good advice.
Yeah. So 2 good messages to finish with. Put in place best practice and bring patients in to play that role as well.
Because they will help deliver.
Excellent. Neil, thank you for your time. It's been a pleasure to have a discussion today.
Thanks, Michael.
Thank you very
Pleasure.
much. That brings us to the end of another edition of the Pioneering Patient Podcast. Thank you to the Global Remission Coalition for their support. Thank you to you for watching. Please remember to subscribe and like. And finally, please remember to take good care of your health.